So I'll be taking the for side in terms of should Gleason score 6 be called cancer. First of all, in terms of pathological arguments favoring calling it cancer. Molecularly, it is cancer. There's a loss of basal cells like all carcinomas. There's a higher incidence of TMPRSS2 ERG fusions, which is independent of grade. And you can see identical genomic breakpoints compared to Gleason pattern 4 in a given focus of cancer. There's also a higher incidence of loss of P10 in Gleason score 6 cancer. And in Gleason score 6 cancer, you can see methylation of GST-pi, which you do not see in benign tissue. Also, morphologically, under the microscope, it's cancer. Cytologically, it's indistinguishable from higher grade cancer in many cases. Architecturally, it's infiltrative like cancer. You can see perineural invasion, extraprostatic extension, and you can see it merging in with higher grade cancer. Here we can see a nerve in the middle. We can see Gleason score 6 cancer wrapping around a nerve. You don't see that in benign glands. Here we can see Gleason score 6 cancer. It's invading around the seminal vesicle, outside of the prostate. This is cancer. You don't see this with benign glands. Also, what would we call it if we don't call it cancer? Some people have said we'll call it a precancer, tumor of low malignant potential, tumor of borderline malignancy. The term idle indolent tumor of a low malignant potential has also been raised. So we'll pretend you had a case of, let's say, Gleason score 6 cancer, but now you call it an idle tumor, and it involved 8 cores, 80%, 70%, 60%, 50%, a lot of cancer. Patient has a high PSA of over 20, palpable tumor on rectal exam. We know this is a tumor that needs treatment. This is not an indolent tumor. So to call it some type of an indolent tumor without using the word cancer would be very misleading. Even if you put some kind of a notation or an asterisk saying, well, we may call it cancer with the Gleason 6 if you had a certain number of cores or PSA, and if you didn't have a certain number of cores, well, then we call it an idle tumor. Over time, people will ignore that little asterisk or notation, and basically they just won't consider it cancer. And the key thing is they may not consider it a serious risk and take it seriously. The other thing is what happens if you have a case with some cores are Gleason 6 and some cores are Gleason 7? It's all the same tumor. Does it make sense to call some of it idle tumor, for example, or precancer, and the other Gleason score 7? And when you have a cancer that has a mixture of pattern 3 and 4, 3 plus 4, 4 plus 3, if it's a pure pattern 3, the people who say we shouldn't call it cancer, they're not going to call it cancer, but all of a sudden now that pattern 3 is mixed with pattern 4, and now they're calling the whole thing cancer. Again, it's not consistent. And we know that pattern 3 modulates the effect of pattern 4, and it's all cancer. We also know there's an upgrading of biopsy of Gleason score 6. About 20% of the time when you have a Gleason 6 on biopsy, there'll be Gleason 7 or higher due to sampling area in the radical prostatectomy. So the problem is if you call it, again, a non-cancer, that patient 20% of the time would have higher grade, more aggressive cancer. There's also potential medical legal problems. Maybe not as much a problem in Israel, definitely a problem in the United States. I'm unaware of any lawsuits where pathologists called it a Gleason 6 where on review it was a Gleason 7. But I could foresee a lawsuit where, for example, a pathologist calls a Gleason 6, what we call today, they call it an idle tumor, and maybe 2 years go by, the patient progresses with tumor, develops trouble, and then somebody goes back to look at that slide and says, well, 2 years ago I would have called it a Gleason 7, not an idle tumor, and all of a sudden they say, well, you missed the cancer when you call it an idle tumor. When it's not a matter of missing the cancer if you called it an idle tumor, it's semantics. It's still a Gleason score 6 cancer, and it's just a matter of grading subjectivity, which we know can occur. But the most important reason why I think we have to keep on calling Gleason score 6 cancer is to make sure that patients are followed up. If we do not call it cancer, a significant number of men with Gleason score 6 cancer will not be followed as closely, and they potentially can progress to incurable cancer or have cancer within them that is not sampled that is higher grade, which, as I mentioned, happens in about 20% of the time. And I think there are analogies that we can use in other organ systems. We have squamous cell carcinoma, basal cell carcinoma of the skin. We call them carcinomas. They rarely metastasize. We still call them cancer. The public has been educated. They know that these are, for the most part, not lethal cancers, and they can deal with this issue in a rational manner. So what I think we need is public education. We have to educate patients that most Gleason score 6 cancers can be followed with active surveillance. You can tell a patient you have a very good type of cancer that in general does not cause harm. However, there is a risk that there may be more aggressive cancer in you that we missed, or that the cancer could change over time, and we need to make sure that we follow you closely. I think public perception of prostate cancer can change. 10 years ago when I talked to patients, and I talk to patients every day, no one would bring up active surveillance. Today, more and more men are asking for active surveillance because of relatively few articles in the lay press. I think the key is that urologists have to buy into the concept of good cancers, Gleason score 6, educate the appropriate patients about active surveillance, because urologists are typically the first patients who the first doctors that patients will see following their diagnosis. As was mentioned, there was a problem. The current lowest grade of prostate cancer that we call is a Gleason score 6. For the practical purposes, we don't diagnose Gleason scores 2 through 4 anymore because of poor correlation with radical prostatectomy grade, poor reproducibility amongst expert pathologists. So what happens is patients are told they have a Gleason score 6 cancer, but they read on the internet that the Gleason scores go from 2 to 10. They think their tumor's in the middle of aggressiveness range, and they're worried about this cancer. So what I do basically in all my pathology reports, I will diagnose Gleason score 6 cancer, I'll describe how much cancer is in the specimen, and then I basically add this comment. I say the overall Gleason score for this case is based on the core with the highest Gleason score, and Gleason scores can be grouped and range from prognostic grade group 1, most favorable, to prognostic grade group 5, least favorable. I then add Gleason score less than or equal to 6 as prognostic grade group 1, 3 plus 4 equals 7, group 2, 4 plus 3, group 3, 8, group 4, 9 through 10 is group 5. The International Society of Urological Pathology is meeting later this year, and potentially, hopefully, we will come up with an International Society of Urological Pathology grade that will put, in addition to Gleason, describing these groups 1 through 5 to put, in a sense, Gleason score back into the right framework. So patients aren't worried as much when they were told they have a Gleason score 6. So in summary, I don't think there's a need for changing how we call Gleason score 6 cancer. Rather, I think there's a need to change what patients think when they have Gleason score 6 cancer. Urologists need to reassure and educate patients, and I think it'll help if we modify how we report Gleason scores to more accurately reflect their behavior. Thank you.
Thank you. Dr. Klotz will try to convince us to abandon the term Gleason 6 cancer.
Okay. It is not easy to follow Jonathan Epstein on this subject. And I will make the case that this is not a black and white argument, and there is a great deal of evidence that we should consider thinking of this differently. The issues are the overall context of the word cancer, the overdiagnosis problem that we're a part of, the hallmarks of cancer, does Gleason 3 characterize them, lessons from histology, natural history data, models, and the impact of adopting a non-cancer term. So first of all, it's a hot topic. Many recent articles published that address this issue. Should it be relabeled as cancer? We're not alone in the problem of finding a lesion that is indolent, probably poses no threat to the patient, diagnosed as a result of attempts at finding disease earlier. This is just an example of some conditions where the definition of abnormal has been changed, resulting in many millions of men and women suddenly diagnosed with a disease that they're not aware of, that probably in many cases poses no threat to their life. A lot of constituencies are grappling with this. One of the issues is that the word cancer has different meanings depending on whether you're the patient, the physician, an insurer, a public policy person. Here's Dorland's Medical Dictionary, a neoplastic disease, the natural course of which is fatal. We are not talking about that kind of condition with Gleason 6 prostate cancer. Now it says there's a transformation of normal body cells into malignant ones, and malignant means a very dangerous or harmful and influence or effect tending to produce death, as bubonic plague, or a tumor characterized by uncontrolled growth, cancerous, invasive, or metastatic. Now is Gleason 3 one of those? A final point about the context, that there's many diseases where we have this phenomenon of, is it a real cancer or not? It's not just prostate cancer. This landmark article by Hanahan and Weinberg, updated in Cell 2011, the 8 hallmarks of cancer, and I can't go into this in any detail, but just to say, There's a gray zone here. So by and large, if you look at the molecular characteristics of cancer that have been defined for each one of the molecular pathways of cancer, which includes things like apoptosis, angiogenesis, proliferation, responsiveness to growth signals, and so on, there is, by and large, a very significant difference between Gleason 3, where the vast majority of these tend to be negative, non-mutated, present if it's a tumor suppressor gene, and absent in Gleason 4 and 5. From a molecular perspective, there's a major difference. Now, there are exceptions. John mentioned Tempress 2-ERG, which is the translocation is present in about 40% of Gleason 3. Another example is P10. It's been recently reported about 20% of Gleason 3 have lost P10 or deleted. Nonetheless, for the vast majority, Gleason 3 has normal molecular characteristics. Then there's the clinical side. Again, this is a long story, but 2 or 3 examples. This is 24,000 men having a radical prostatectomy at centers of excellence reported by some heavy hitters in the field. And essentially for Gleason 6 with 20-year follow-up, the prostate cancer mortality is 0.2%. Now, they reviewed these outliers at the group that came from Sloan Kettering, and every one of them had elements of Gleason pattern 4 present in the radical prostatectomy specimen. So in fact, it's plausible that the metastatic rate for Gleason 6, at least treated surgically, is 0. No patients who metastasized prior to surgery, no patients who had a local failure followed by metastasis. This is a lymph node study, 14,000 cases, only 22 true Gleason 6 that metastasized the nodes, all had elements of higher grade cancer in the prostate. So it's plausible that there is virtually not a single patient reported in the world who has true Gleason pattern 3 who's gone on to metastasize and die of prostate cancer. Pivot study, no benefit of surgery for the low grade patients, again reinforcing the indolent natural history. Now, biology is never so black and white, and it's actually extraordinary that simple histology would be so unbelievably predictive as to have no patients in the world who metastasize. And of course, there's exceptions. And there's the P10 story that I mentioned, and this just shows the problem of heterogeneity. So here's a P10 staining showing intraluminal heterogeneity of P10. Of course, you're going to get this in tumors. And this is one sobering single case study reported recently from Hopkins. Probably John Epstein was the pathologist on this. They took a guy who was diagnosed at the age of 47 with Gleason 4+3, node positive. He died 17 years later, whole genome sequencing on every one of his different metastatic sites and the prostate. And the remarkable thing is that there was genetic homology between all of the metastases, which looked clonal, and not the high-grade cancer, but a little microfocus, 3 millimeters in diameter of Gleason pattern 3. So what this shows you is there is such a thing as prehistologic genetic alterations that confer a metastatic phenotype on the cells. Does this mean that these very rare cases should determine how we approach this disease? It does not. And keep in mind that this is a little focus of 3 and a sea of pattern 4, not at all the microfocal 3 in a normal prostate that we're talking about. But some humility is called for when you're talking about biology, and I think all of us know that. So the concept here is to move away from a kind of single pathway. Michael Droller, who's here, published this diagram, moving away from the 3 going to 4 going to metastasis to a bifurcated pattern of molecular progression with a proliferative pathway going to Gleason 3 and basically stopping, and a dysplastic growth pathway going to high-grade PIN, Gleason 4, 5, and metastasis, and very rarely 3 progressing to 4. So what you call things makes a difference. These are both cats. These are both, I suppose, we're talking technically about cancer, but the nomenclature makes a difference. There have been these proposals to call these indolent lesions idle tumors, indolent lesions of epithelial origin. which would focus attention on how to reduce or eliminate the over-treatment problem, and also pun lump, prostatic neoplasia of low malignant potential, as we have with bladder. And of course, this is not just prostate. Dr. Esserman is a breast cancer specialist, and the many benefits of changing the terminology, decreased anxiety, reduction of the overdiagnosis and overtreatment problem. It would enhance the search for tests to find clinically significant disease in this patient. No one's saying not to continue to follow these patients, but to manage them conservatively, less public confusion, enhance legitimacy for the patients who have the real disease. There's a move away from any screening and diagnosis for prostate cancer because of this problem. This is not just recognized as our problem. The NCI had a working group on this subject, and here was the consensus: recognize overdiagnosis occurs and it's common, embrace the development of new terminology. So, you know, everyone recognizes it's not going to be perfect, but the benefits of moving to a different terminology that does not evoke the frightening concept of malignancy and death from metastasis would be very favorable. Observational registries, strategies to lower overdiagnosis, and so on. And the clinical implications of this would be conservative management for most men with Gleason 6. You don't have to grapple with the patient's fear about cancer. Age would, I think, be less of an issue if the word cancer was not being used. The volume of disease we know, and this is going to come up, I think, later in the meeting, the volume of low-grade cancer is mainly significant because it is associated with an increased risk of higher-grade cancer, not that it harbors metastatic potential on its own. You need to be sure that the patient isn't harboring higher-grade cancer elsewhere in the prostate. And finally, that grade progression occurs, but it's uncommon. Our estimate is about 1% per year. So I think fundamentally there would be a large benefit to patients, to society, to changing the nomenclature to a term that was less anxiety-provoking. And the rare exceptions to the benign natural history of prostate cancer, which are indeed very rare, should not prevent this. Thank you.